All right, here we go. My name is Preston Egizi. This is Respiratory Care Course 443 in the fall of 2024, Term 1. I have chosen to do my project on understanding and managing chronic obstructive pulmonary disease, otherwise known as COPD. Objectives for my PowerPoint project are going to be as follows. Define COPD based on understanding of the pathophysiology, recognize causes, signs, and symptoms, as well as diagnoses, and be able to recommend appropriate interventions based on risk factors, status, and progression of the disease. Let's jump right into it. So first and foremost, chronic obstructive pulmonary disease is characterized by a persistent, irreversible limitation of airflow through the lungs and tissue destruction. Looking at the slide, we can see normal circumstances, which air is brought to the lungs, passing through the conducting zone of the airways, which extends from the nose to the bronchioles, before getting to the respiratory zone, which begins at the respiratory bronchioles and ends where gas is exchanged in the alveoli. So in inspiration, the diaphragm and intercostal muscles contract, causing a flattening of the diaphragm and elevation of the chest wall, respectively. This increases the volume of the lungs, causing pressure within them to fall so that air is drawn in. In exhalation, it's the opposite. The diaphragm and the intercostal muscles relax and lung volume reduces, causing pressure to rise and force air out. So, looking at COPD, there is a limitation in this airflow, primarily due to two main mechanisms, which you can see on the left there: loss of elastic recoil and narrowing of the airways. A large driver for both mechanisms is inflammation, which is generally generated within the lungs as a result of exposure to inhaled toxins, most commonly cigarette smoking. Neutrophils and macrophages are recruited and secrete proteases, such as neutrophil elastase and matrix metalloproteinase, which are enzymes involved in breaking down proteins as part of normal repair. These are typically counterbalanced by antiproteases like alpha-1 antitrypsin, but as a result of the chronic inflammation, there's excess protease activity causing destruction of lung tissue. This leads to less support for the alveoli, which causes the reduced elastic recoil. This also causes them to enlarge, which is the hallmark of emphysema. This also causes the small airways to collapse during inspiration due to the reduced structural support. When this takes place, air is trapped, which ultimately leads to our hyperinflation. Inflammation and the recruitment of neutrophils increases oxygen-free radicals and causes mucosal edema, hypersecretions, fibrosis, and bronchoconstriction, which all lead to narrowed airways with an increased resistance to airflow. COPD patients are also have impaired mucociliary function, which leads them prone to infection, and repeated infection increases inflammation, which contributes to the disease progression. Together, the two main mechanisms cause an increased work of breathing, which causes decreased ventilation, which leads to our hypoxia and hypercapnia. So the principal causes of COPD is exposure to inhaled chemicals, primarily smoking, where it is studied that up to 90% of cases are due to smoking. Other exposures, such as pollution, mineral dust, or chemicals, also increase the risk, but are not as commonly the cause as smoking. Genetics are also a cause, with many genetic variants showing increased likelihood of the development of COPD, but in particular, alpha-1 antitrypsin deficiency, again leading to a relative excess of protease activity. Signs and symptoms of COPD which is typically a gradual onset due to a 20-pack year smoking history, are dyspnea, which is the most common finding that is typically persistent and worsening and gets worse with exercise, but as the disease progresses, it can be present at rest. The cough is also common, which may be productive or non-productive. In this instance, sputum characteristics like color and volume can be useful markers for exacerbations. Traditionally, for a diagnosis of chronic bronchitis, the cough must be consecutive for 3 months over 2 consecutive years with no other explanation. Recurrent wheezing, respiratory tract infections, fatigue, weight loss, and chest tightness are also other common findings. So a classic description of the 2 main types of COPD are the blue bloaters to describe chronic bronchitis and pink puffers to describe emphysema. Blue bloaters have predominant features of a productive cough, dyspnea, obesity, and cyanosis as a result of reduced oxygen levels in the blood. And pink puffers are characterized by a normal or thin body habitus and pursed-lip breathing that assists the bronchioles from collapsing in attempts to improve ventilation. Most COPD patients typically have an overlap of both characteristics. Non-specific physical exam findings, we're looking at tachypnea, accessory muscle use, barrel-chested, which is common secondary to hyperinflation, and upon auscultation, coarse crackles due to reopening of collapsed airways and the presence of mucus. In cases where hypercapnia is present, they can also appear asterixis, which is a tremor to the arm. Complications include acute deteriorations or exacerbations, defined as a worsening of symptoms from the patient's usual stable state. They can happen secondary to infections, pulmonary embolisms, heart failure, arrhythmias, and myocardial infarctions. Pulmonary hypertension may develop due to chronic hypoxemia. When the lung vasculature responds and remodels, this can lead to right heart failure. And pneumothorax can also be a result secondary to a rupture of the bullae. Diagnosis is based on clinical history and by demonstrating an obstructive pattern on spirometry that is irreversible. The Global Initiative for COPD, otherwise known as GOLD criteria, includes a post-bronchodilator force expiratory volume in 1 second to a forced vital capacity ratio of less than 0.7. The FEV1 can also be used to indicate the severity of obstruction, with more than 80% of predicted value being the mildest form of COPD and less than 30% of predicted value indicating severe COPD. The COPD assessment test, otherwise known as the CAT score, can be used to assess symptom severity, and the number of exacerbations in the past can help reduce future exacerbation risk. Based on the information provided, we're looking at the photo below here. Patients are categorized into GOLD groups A, B, C, and D, with Group A, or a CAT score of less than 10, reflecting mild COPD, with 1 or less exacerbations per year. Group B is increased symptoms, or a CAT score greater than 10, with still less than 1 exacerbation per year. Group C is reflective of greater than or equal to 2 exacerbations per year, and Group D, which is most severe, leads to hospitalization with greater than or equal to 2 exacerbations per year. GOLD groups can also impact treatment routines, which we will look at a later slide. Initial testing can be done by pulse oximetry. An ABG can be done to rule out respiratory failure. A full blood workup should be done to look for anemia or polycythemia as a result of chronic hypoxemia. A chest x-ray, which is not diagnostic but can include an increased AP diameter, larger intercostal spaces, and flattening of the diaphragm, which are all suggestive of COPD. Genetic testing is not routinely done, but for patients under the age of 45 with worsening symptoms, should be screened for alpha-1 antitrypsin deficiency. So in acute exacerbations, treatment generally involves the use of short-acting beta agonists such as albuterol, either inhaled or through a nebulizer, and a short-acting muscarinic antagonist such as ipratropium bromide. In general, most patients with COPD will have target O2 saturations from 88 to 92%. This is because the excess oxygen may suppress the drive for ventilation and precipitate hypercapnia and respiratory failure. Alongside these, a systemic steroid can be given, and an antibiotic may be used if an infection is suspected. Ventilation may be required in some cases, especially in respiratory failure secondary to hypercapnia. The overall aims of treatment in stable COPD is to reduce the symptom burden, as well as number and severity of exacerbations, and reduce the mortality rates. First-line measures include smoking cessation or removal to the exposure of the damaging substance, are shown to be the factors with the greatest capacity to influence the course of the disease process, along with pulmonary rehabilitation, including aerobic exercises, strength training, and education, as well as vaccines. For example, the flu and the COVID vaccines, they're all first-line measures for non-pharmacological interventions. Pharmacological management of the disease involves beta agonists, which increases intracellular cyclic AMP and leads to smooth muscle relaxation, while muscarinic antagonists block cholinergic receptors on the respiratory smooth muscle, which also promotes smooth muscle relaxation. These medications usually come in inhaler form, and so technique in using them is vastly important. Looking at the initial treatment based on the GOLD groups that we can see below, bronchodilators are in Group A, which can involve short or long-term options, more specifically short or long-acting beta-2 agonists, or short or long-acting anti-muscarinic antagonists. Long-acting agents are more commonly used, but short-acting agents should be available for immediate relief. Group B uses LABAs and LAMAs, while Group C uses monotherapy, and Group D uses a combination of LAMA and LABA with a potential inhaled corticosteroid if it is indicated through a history of asthma or multiple exacerbations. Depending on the response to therapies, patients can be stepped up through GOLD categories, and there are ongoing exacerbations on triple therapy. A prophylactic antibiotic can be added. In cases of predominant bronchitis with hypersecretions, mucolytics can be used to help break down secretions. Long-term use of oxygen therapy can be recommended in stable patients with oxygen saturations lower than 88% if there's evidence of heart failure or polycythemia. And lastly, surgical options, including a bolectomy, volume reduction surgery, and a lung transplant, are all options. All right, this concludes my presentation. Here are my references. Thank you very much.